abdomen with occasional vomiting and heartburn for last 1 year. No other history of any comorbidities, no history of trauma to the chest or abdomen, no history of hematemesis, melena or jaundice. We presented with diminished, we found that there are diminished vesicular breath sounds over the mid and lower zone of the left lung field. On abdominal examination, nothing could be found. There is on chest X-ray, there is an opacity in the lower zone of the left lung with gas shadow, but no air fluid level. The cardiac shadow is displaced to the right, and there is a normally placed left dome of diaphragm. This is the normally placed left dome of diaphragm. This is the gas shadow, and it is found that there is a mediastinal shift to the right side. An upper J endoscopy was done, which was suggestive of diaphragmatic hernia on the left side. Esophagus and duodenum were found to be normal. This is an upper J endoscopy picture, which shows two rays, one for the gastroesophageal junction and other for the diaphragmatic hernia. Barium swallow was also done. It showed a large part of the fundus and the body of the stomach that has been displaced within the left thoracic cavity. Our impression was that of left diaphragmatic hernia. This is the barium shallow picture, which shows the stomach that has been displaced within the left lower lung cavity. Contrast enhanced CT scan was done, which with the eventration of the left hemidiaphragm with an organoaxial type of gastric volvulus. This is a CT picture which shows the displaced stomach with an air fluid level within the thoracic cavity. The patient was taken up for operation on 5th of January 2011. It was an upper midline incision. The findings were that of a left diaphragmatic hernia. In the large part of the stomach, the transverse colon with omentum had been displaced within the thoracic cavity. At first, the left lobe of the liver was mobilized. The contents were reduced into the abdominal cavity. The sac was everted. The excess redundant portion of the sac was excised, and the defect was closed with 1-0 proline in 2 layers after placing an intercostal drain. These are the paroptotic pictures showing the contents, that is the stomach and the transverse colon that has displaced within the thoracic cavity. This is the intercostal drain that has been placed. This is after the contents are now being reduced. This is the rent in the diaphragm after the redundant portion of the sac has been excised. It has been repaired with proline sutures. Postoperative period was uneventful. The chest drain was removed on the 5th postoperative day, and she was discharged on the 9th postoperative day. This is a post-op X-ray that has been done after 1 month with more or less normally placed left dome of diaphragm, and there is no more gas shadow within the left lung field. Our second case was a 19-year-old male, Sanju Panigrahi, who presented with a low-grade pain in the left upper part of the abdomen, early satiety, intermittent episodes of vomiting for the last 3 months, and there was again no past history of any trauma. On clinical examination, there was absent vesicular breath sounds over the left lower zone of lung, lower zone of the left lung. The heart sounds had shifted to the right side, and on abdominal examination, it was a scaphoid abdomen and otherwise normal. Chest X-ray revealed an elevated left dome of diaphragm. The fundic gas shadow and the colonic gas shadow are inside the elevated dome. This is the chest X-ray showing the fundic gas shadow within the lung cavity. The same picture also here. Contrast enhanced CT scan showed eventration of the left hemidiaphragm. Here the contents were the stomach and the splenic flexure. There was mediastinal shift to the right, and there was pleural thickening. These are the CT pictures showing the displaced stomach with the and the splenic flexure. The patient was operated on the 9th of February, and it was again an upper midline incision. It was found in this case that there was a hypoplastic left dome of diaphragm. There was an eventration with a large diaphragmatic hernia. There are scanty muscle fibers of the diaphragm anteriorly and posteriorly, and the lateral part was found to be membranous. Here the contents were found to be stomach, splenic flexure with omentum, and along with that there is an organoaxial rotation of the stomach. At first, it was an upper midline incision. The left lobe of the liver was at first mobilized. The contents were reduced. The left lung here failed to expand adequately. There was a possibility of an hypoplastic lung in this case. Gastropexy was done in order to fix the stomach. The anterior of the stomach was with the jejunum was fixed 10 centimeters distal to the DJ flexure. It was a non-anastomotic gastrojejunostomy. To prevent the further organoaxial rotation of the stomach, the sac was again everted and the excess sac was excised. The gap was closed with 1-0 proline in 2 layers after placing an intercostal drain. Here, as the diaphragm was, it was an eventration of the diaphragm, and the diaphragm was very lax. It was repaired with an membrane. It was buttressed with a Gore-Tex mesh. These are the pictures which shows the contents that has displaced within the thoracic cavity. Here the contents are being pulled out with great care not to damage the spleen. After the entire contents have been pulled out, this is the lax diaphragm. These are the contents that have been reduced. This is the rent in the diaphragm. It has been the redundant part was excised, and it was at first closed in 2 layers with proline, and then Gore-Tex mesh was used to buttress the diaphragm. It was an uneventful post-operative period. The chest drain was removed on the 6th post-operative day, and patient was discharged on the 10th post-operative day. This is a post-op picture on the first post-op day. Discussion. Coming to discussion, congenital diaphragmatic hernias occurs because of embryological defects in the diaphragm. The diaphragmatic hernias can be divided into 2 categories: congenital defects and the acquired defects. A subset of adults may present with a congenital hernia that was undetected during the childhood. An acquired diaphragmatic hernia stems from all types of trauma. However, the blunt forces account for the majority of them. They mostly present with a marked respiratory distress, decreased breath sounds on the affected side, palpation of the abdominal contents upon insertion of a chest tube, auscultation of the bowel sounds in the chest, paradoxical movement of the abdomen with breathing, or with or without diffuse abdominal pain. The workup is basically chest radiography that can detect in 23 to 73% of cases the diaphragmatic hernias in the initial chest radiograph, with an additional 25% being found on subsequent films. The helical CT increased the sensitivity to 71 to 100% with a higher sensitivity on the right side, on the left side. Treatment is basically, in case of diaphragmatic injury that has been unnoticed for months or years, it is a transthoracic or transabdominal approach that is preferable, thoracoabdominal approach that is preferable because the herniated intra-abdominal contents tend to be firmly attached to the intrathoracic structures, making the transabdominal approach a more difficult one. The small defects may be repaired using interrupted horizontal sutures or figure-of-8 sutures. Larger defects may be repaired with continuous or double-layered sutures. Absorbable sutures are, however, associated with a high risk of recurrence. Synthetic material such as mesh is rarely required but may be indicated in occasional patients with large defects. The mesh is sutured to the free edges of the defect using interrupted non-absorbable sutures. Coming to eventration of the diaphragm. It is a pathological condition defined by permanent elevation of an immobile hemidiaphragm that cannot participate actively in respiration. It is a congenital anomaly caused by failure of the muscularization of the dome of diaphragm. Eventrations are frequently unilateral. They are more common in males and on the left side. Partial eventration is more common on the right side and is of equal sex distribution. Most adults with congenital diaphragmatic eventrations are asymptomatic and do not require any surgical treatment. They mostly present with respiratory distress, tachypnea, tachycardia, or even cyanosis. Chest pain or cardiac arrhythmias may be present. Abdominal symptoms like epigastric pain, dysphagia, dyspepsia, belching, and gastroesophageal reflux may also be found. Diagnosis is mainly thoracic CT scan. An upper abdominal CT is used to exclude subdiaphragmatic abnormalities such as the abscess or a Chilaiditi's syndrome. Therefore, it is a rare condition when pain occurs due to transposition of a loop of large intestine, usually the transverse colon, in between the diaphragm and the liver, and is visible on plain abdominal X-ray or chest X-ray, which may be associated with a diaphragmatic paralysis. Treatment: the goals of surgical therapy should be to restore the diaphragm to a normal location within the involved hemithorax, to restore normal capacity to the hemithorax to allow the lung growth in infants and children only, to restore normal visceral location within the abdomen, and to stabilize the mediastinum by eliminating paradoxical motion of the diaphragm. The treatment options are either open operative repair or minimally invasive repair. Open operative repair, it is a diaphragmatic plication. Resection of the redundant diaphragmatic tissue and establishing in its place a rigid diaphragmatic structure using Gore-Tex mesh is another option. Or it may be a minimally invasive plication of the diaphragm. Thank you.